That was just right. I know. Hi, everyone. Can y'all hear me? Yeah. It's working, I think. Okay. Hi, everybody. I'm Phyllis Leverich. I'm the Western Slope Outreach Coordinator for Parkinson Association of the Rockies. Just one announcement before we start. Our E3 conference is September 30th in Denver. It'll be live streamed and recorded. So for more information, go to visit our website. And for the support group members, next month's support group meeting is canceled. So our next meeting will be on October 9th. Okay. So first off, I'd like to thank our sponsors. We have Acadia, Abbott, AbbVie, Amneal, Supernus, Medtronic, and Boston Scientific. And if you guys want to come up, yeah.
Hi, my name's Taryn Shaftel. I'm with Medtronic. We have a device for a deep brain stimulator for Parkinson's. Our big differentiator right now that's just come out is our adaptive stimulation, adapts with your brain signals and senses, and it has regular DBS as well. So come talk to me if you want to hear more.
Hello, my name is Callie Hughes. I'm with Supernus. We have two different products. We have GoCovery, which is for dyskinesia. It's a single bedtime dose. And then we have a NAPCO, which is going to be a non-surgical device for off time. If you have any questions, you can come talk to me. Okay. My name is Callie Hughes. I'm with Supernus. We have two different products. We have GoCovery, which is for dyskinesia. It's a single bedtime dose. And then we have a NAPCO, which is a non-surgical pump for off time.
I'm usually pretty loud, but I'll try to get close. My name is Kylie Rubo, and I'm with Boston Scientific. We also do deep brain stimulation. We've had several exciting advancements this year, including a longer electrode, so you can stimulate a larger area of the brain while reducing side effect, as well as some new software that helps create a patient-specific stimulation field based on your anatomy. So if you'd like to learn a little bit more, please visit me after the talk.
Good morning. I'm Michelle Odenbach, and I'm with Amneal Pharmaceuticals. You might be familiar with our first extended release drug, Rytary. We also just launched one last year. That's kind of that new and improved version called Crexont. It's an extended release carbidopa-levodopa, just providing you with more good on time with less frequent dosing. So if you have any questions, let me know.
Good morning. I'm Cindy Kirkendall,
And I'm Alex Rice, and we're with Abbott.
also deep brain stimulation. So one of three companies in the DBS market. Our kind of differentiator right now is remote programming, being able to connect to your provider over a secure Wi-Fi connection. So folks that are living out of town, further from clinics, can actually have programming done remotely without actually having to go to the clinic.
Yeah, we have the smallest rechargeable IPG on the market, so and longest lasting as well. In theory, you should only need to charge about 10 times a year. And outside of that, I think Cindy hit everything else. So after the talk, come see us, ask us any questions you have.
Thank you. Okay, I'd like to now introduce Doug Hornberger. Doug is a certified physician's assistant working with Dr. David Wheeler at Wyoming Neurologic Associates in Casper, Wyoming. Before moving to Casper to help take care of his parents, he practiced neurology at UC Health for 16 years. And Douglas is also part of PAR's medical advisory board. So welcome, Douglas. Doug, sorry.
All right. Well, welcome everybody. Can everybody hear me okay? Does that sound okay? All right. Well, I want to thank everybody for coming out today. It's great to see everybody in this kind of support. I'd also like to take a moment and just thank Jody and Phyllis with the Parkinsons Association for putting this together. And I would also like to recognize my wonderful wife and daughter in the back, Lisa Hornberger and Hannah Hornberger. And if anybody needs a wonderful speech language pathologist, Lisa is a speech therapist at UC Health here in Steamboat. So let's see. Yeah.
There you go.
How about that? Yeah. Okay. All right. I want to ask everybody, what's the first thing you think of when you think of Parkinson's disease in terms of symptoms? Yeah. Bradykinesia. Yeah. A little tremor. What was that? Freezing of face. Freezing of face. Otherwise known as fog. Yeah. And those are all absolutely correct. And those are all what we think about with idiopathic Parkinson's disease. Those are called motor symptoms. Now, one thing we don't think a lot about are non-motor symptoms. These are the things that maybe you don't see quite as much. Maybe you don't see the masked faces or the tremor for the shuffling gait. And that's what I would like to talk about today. Specifically dementia, psychosis, some of the anxiety and depressions that go along with this, apathy, impulse control disorder, and some of the sleep disorders. Those are things you probably don't think a lot about, but as you'll see, they're probably as prevalent as your motor symptoms are. And what I hope that you'll walk away with today is an understanding of how often we see these, what they look like, and what can we do for them. The other thing I was going to say is I am a very informal person. So please, I would rather have this be a conversation than me just downloading data throughout the slides. Please feel free, if you have a question, to just stop me, say, hey, Doug, what about this? And we'll turn this into a conversation, okay? Well, helps if you hit the right button. All right. These are some of the common terms you're going to see. For example, for Parkinson's disease, you'll see PD. For Lewy body dementia, LBD. Why did they put these up here? Because I am a terrible typist. And for me to type all these out, I wouldn't have got the presentation done. So 2 capital letters or 3 capital letters is really nice. There's a couple of other things you'll see. Prevalence. When you see the word prevalence, think of the proportion of the population that has that disorder at a point in time. August 23rd, 2025. How many people here have tremor? That's the prevalence. If we take a look over time, that's called the period prevalence. So between August 1st and August 30th, how many people have that? In contrast to incidence, incidence is the number of new cases in a specific period of time, and then how does that change in time? You won't see these words a lot, but if you do see them, that's what they mean.
So my husband has vascular Parkinsonism. That's not listed as a common term.
Yeah, so vascular Parkinsonism is probably a combination. If we were to look at that brain MRI, we would probably see a lot of small vessel ischemia, possibly stroke.
No stroke.
No stroke, but a lot of small vessel ischemia. Yeah. If you take that, if we took a pure vascular dementia person, they wouldn't have signs of a tremor, bradykinesia. Where it becomes a little difficult is, has some of that happened in the basal ganglia? And if it has, that's, you'll see here in a moment, I'm going to put a slide up. If the stroke or the ischemia has happened there, well, is it really Parkinson's disease? Or is it Parkinsonism secondary to a vascular event? And that's what I would estimate that's what that is. Yeah. I will get the right button before the end of the presentation, so. Yes. I'm gonna show, a great question. I'm gonna show that in just a moment. We're gonna do a little bit of anatomy on the Parkinson's, the basal ganglia, and that system.
We can't hear the questions that are aimed at you and.
How about if I repeat them? Okay. Yeah, so the question was, does everybody know what the basal ganglia is? And I'm going to show, we're going to do some basic anatomy. You didn't know you were in for an anatomy lesson today, did you? So we'll talk a little bit about that. Let's talk about Parkinson's for a moment. What do we know? We know that 1% of people that are age 60 probably have Parkinson's or have the beginnings of. And when we get up into our 70s and 80s, that number goes up quite a bit, 4 to 5%. If we take a look at that body of patients, and we talk about the non-motor symptoms, not the tremor, not the bradykinesia, but the non-motor, 61% of patients will have some sort of neuropsychiatric finding. So 61%, that's quite a bit. I've put out some numbers here, 30% of dementia in Parkinson's, 27% will have hallucinations. We're going to spend a lot of time on hallucinations. Hallucinations are something that can be very scary to people. Yet in your routine visit, it may not come up very often when you're talking with your neurologist. Usually it's, how's your tremor? Are you walking okay? Are you falling? Well, if you're having some hallucinations as we described them today, I would recommend bringing that up to your neurologist the next time you see them. All right. Here's the anatomy of what happens in Parkinson's. I always think of the example of trying to reach for a glass. Okay, see if I can make the pointer work. Right here, nope, doesn't work. That red that comes around is the caudate nucleus. And that kind of gives us the start of the signal. I want to move my hand towards that glass. It then works in conjunction with the putamen, which starts that initiation of it. From the putamen, it'll go into the globus pallidus, which talks about the intensity, and you'll see that big round red. That's the putamen. Then those dotted lines in the inside is the globus pallidus. So you have the start of the stop, then the initiation, and then the intensity of the movement. And then you'll get to the subthalamic nucleus where it'll say, stop here, or move a little to the left. Okay. So that's the basic anatomy of the basal ganglia and what each of those structures do. When we talk about the substantia nigra, which is, it doesn't show, that little red or red dot in the pons, there's a blue one right below it, and then the red one. That is where dopamine is produced. I think a dopamine is our gas. Get in a car, you don't have any gas, the car's not going to run. The same with this system. If you don't have enough dopamine, you're going to have tremor. You're going to have shuffling. You're going to have other symptoms. When you look at the amygdala, the nucleus accumbens, these are more tied to emotion and reward. They probably have a closer tie to some of the things we're going to talk about today than the actual motor symptoms. Yeah.
What exactly is the limbic structure?
The limbic structure is this part where that red is. Most of that red, that's going to be part of the limbic system.
The circle of red?
Where it curves and then it comes down in. Okay, so with this, you'll see the substantia nigra right there, the two little red dots. What happens is we have loss of dopamine cells in that area. They can't produce the dopamine to come up into the basal ganglia and go through all those things we talked about. That's where you get your tremor, bradykinesia, things of that nature. Now there's another system which you might not be as familiar with, and this is the alpha-synucleinopathies. Alpha-synuclein is a protein in the brain. And what happens in the synucleinopathies is they will start to fold. When they fold, they will cause difficulty with the neuron to function the way it should, which then can lead to decreased dopamine. You'll see this in Parkinson's disease, Lewy body dementia, and then I'm sure you've probably heard of some of the Parkinson plus syndromes, multiple system atrophy, corticobascular degeneration, progressive supranuclear pulse. We'll see some of this in those types of Parkinson's patients. All right, before I go there, when you hear the word dementia, what do you think? Alzheimer's. What else do you? Forgetfulness, that's right. So actually, dementia is an umbrella term. It covers Alzheimer's, which is appropriate. It's the most common of our dementias. But it also is Lewy body dementia, vascular dementia, frontotemporal dementia, sometimes interchanged with Pick's disease. You can have encephalopathies such as Wernicke's syndrome, which is a loss of vitamin B1, which we'll see often with people that have alcohol overuse issues. And they'll present as a dementia. We're going to spend time on Lewy body. That's the one that is most associated with Parkinson's disease. That Lewy body dementia is also an umbrella term, and it covers Parkinson's disease dementia and dementia of Lewy bodies. And you'll see in a few slides the very scientific way we decide which one is which.
So,
yeah.
can you talk about the office?
Sure. The alpha synuclein is a protein within our brain.
Proteins are good.
It is. The problem is it starts to fold, so it becomes disformed. When it becomes disformed, think of it this way. Think of it as you're going down the interstate and there's a big pothole. That pothole is going to slow you down, or it's going to cause you to wreck. Well, that's what the folding that alpha synuclein does. Well, when you can't transmit those neurotransmitters as well, you're not going to get from point A to point B as well as you would like, causing a dysfunction in whatever it is. These are always usually based on where the loss of synuclein or the placement is, to what kind of symptom you'll have. It's something that's we're fine, and we'll talk more about this in a little bit, but we're starting to make some advancements in biomarkers. For example, a year ago, 2 years ago, you could only get things to look at neurofibrillary tangles, amyloid plaques through CSF, which is a fairly invasive process. Nobody likes getting a needle in their back. They've now advanced to where we can get that out of the serum. What my next hope is that we don't have a way to say the ratio of neurofibrillary tangles to amyloid plaque means this, or if there's a neurofilament light chain, but there's none of this or this, what does that mean? But I'm hopeful that we will get there in the near future. So when we do those tests, we can say, oh, well, this is completely a neurofibrillary tangle. There's no amyloid here. We know there's some association with Alzheimer's, but there's probably a greater association with one of the alpha-synucleinopathies. So this is what we should be looking at. We're not there, but I think we'll make advances towards that. Does that answer the question?
Yeah, I just hear a lot about it.
Yeah, I think you're going to hear more and more about it. It's something, I remember when I first started practicing and I would see somebody with memory issue. You would do a mini mental stat or a MOCA test and go, oh, you have dementia here, take this. We've refined that, and while it is certainly not exact at this time, we defined a way that we can start to tease things out, to kind of say, oh, this is probably more along the lines of a frontal temporal dementia, or oh boy, this looks like vascular dementia all day long, which doesn't necessarily change our therapy for it. But what it does is it gives us target for further research to see what we can do to make that better. Okay. So if we take a look at Parkinson's disease dementia versus dementia of Lewy body, you'll see that about 30% of PD patients will have a dementia in their lifetime. Pretty high. We'll also see that if I took 100 people that didn't have Parkinson's and 100 people that have Parkinson's, you're going to have 4 to 6 more times of dementia in the Parkinson's patients than you are in the non-Parkinson's patients. So we know that there's a good chance, not for sure, but there's a good chance that that can happen. And so we should be, as providers, looking at that and saying, how's your memory? You feel like you're having some troubles with focus, or tell me about that. Compared to dementia of Lewy body, there's about 30% of the whole dementia population that has this. If you break it down, looking at Medicare claims, they'll say it's about even. Parkinson's disease dementia versus dementia of Lewy bodies. And again, I'm going to show you the very scientific way here in a moment, how we differentiate them in a moment, okay? I told you I was going to find the right button. All right. How does this compare? So you'll start to see the Lewy body dementias more in the 50s, early 60s, as you compare the Alzheimer's disease, which is going to be more in the 70s and 80s. We know that Lewy body dementia is more progressive than Alzheimer's disease. Another good reason to get on top of it as best we can. It seems that there is more prevalence in males, 1.6 to 1. Sorry, guys, but that's what the data shows. For some reason, there's a pretty big population in the Asian countries that show this. We don't really know in the Black and the Hispanic communities. It's not because they don't have it. It's probably because they have less access to medical care, that when it does get diagnosed, it's in late stage or later stages. And so it's like, well, is it really this or this? And there's a higher prevalence of hypertension and diabetes in those two groups. So you'll see more vascular dementia in those types. Okay, there'll be a test on this at the end. I'd like you to commit this to memory. And I show this because differentiating the dementias can be somewhat challenging sometimes. While we've made advances, our tools are still crude, I guess I would say. One way that we can do that is by looking at what's the pattern of the person's deficit. Are they having difficulty in visual spatial domain? Are they having difficulty in speech domain? Are they having difficulty in executive domain? When we look at Lewy body dementia, remember, Lewy body dementia is that umbrella over dementia with Lewy body and Parkinson's disease dementia. These will usually fall out. Executive dysfunction, attentional dysfunction, and visual spatial dysfunction. How many people have been with your provider and pull out a piece of paper and say, draw a line here, draw this cube, or remember these 5 words, I'm gonna ask you later, or what's today's date? Has anybody ever done one of those? Yeah. So that's the tool we use. It can be the mini mental status exam or the Montreal cognitive assessment. We use the MOCA. That's what we look for. When I give that test, I'm saying, what areas, what domains is this person having difficulties in? And then you kind of take that little piece of the puzzle and you set it right there. You say, okay, what else do I need to know? So how do we start to differentiate? As I mentioned, in the Lewy body dementia, you're going to have early and prominent deficits in the attentional, executive, and visual spatial regions. Compared to Alzheimer's disease, which is going to be more episodic memory, can't remember the 5 words, either at the very beginning or on delayed recall. And then we also compare it to the frontotemporal dementias, which there's 2 primary types. There's primary progressive aphasia, where people will have difficulty with speech and they'll start to have memory loss. And then there's the behavioral variant. And the behavioral variant's always very interesting because these people are very disinhibited. They'll come in and say, "You're the ugliest son of a I've ever seen in my life," and you go, "Well, thank you. I appreciate that." I have a couple of these types. It's frontotemporal dementia is a fairly rare dementia, but you know it when you see it, especially in that later stage. How do we differentiate Lewy body dementia with these others? Well, we have this piece of the puzzle. Okay, executive, attentional, and visual spatial. Are they starting to show any signs of Parkinsonism? Are we starting to see a little bit of tremor? Have there been talk of people falling? Are we freezing? Boy, you know, Dad's just a little bit slow. So you start looking for those. You also ask about the hallucinations. Hallucinations, as you'll see in a moment, is a big predictor of dementia in Parkinson's. Well, I think it's almost 20-fold. That if you have hallucinations in Parkinson's disease, there's a higher chance you'll have dementia in your disease progress. And then the third one, and we'll talk more about this in a minute, is REM sleep behavior disorder. So we have this part of the puzzle. Now we take this and say, yeah, it looks like they've got a little bit of tremor and maybe there's some hallucinations going on. So you take that. Here's the very, very, very scientific way of differentiating Parkinson's disease dementia and Lewy body dementia. It's a time thing. When I say scientific, it's very tongue-in-cheek. If you start to have memory issues prior to the start of your Parkinson's motor symptoms, it'll likely get classified as dementia of Lewy bodies. If you start to have the motor symptoms and then a year after you pick up these memory issues, it's going to be Parkinson's disease dementia. This differentiation is under a lot of scrutiny right now. It's very not scientific because you can't remember when you started having memory issues. You know, oh yeah, it was May 14th. You know, and so the hope is going to be that we can start to take out some of these. Well, is this protein abnormal, but not in this, but not in this? and then say, okay, it's probably Lewy body or dementia Lewy bodies. Does it matter right now? No, because we treat them all the same. When it comes to medications and therapy, there's no difference in the treatment. Where it will make a difference is if we can identify that protein or whatever neurotransmitter, and one of these wonderful companies here can develop something that stops that. Now we're on. There is criteria for clinical diagnosis of Lewy body dementia. And what that is it's a concern by the patient or the caregiver that there's a decline in memory. There's an impairment in one of those domains that we talked about, but they're still independent in functional activities. Core and supporting features are important because that is what is used to help make the diagnosis. So core clinical symptoms are those that are fluctuations in the memory. We've already talked about some of these. Hallucinations, REM sleep behavior disorder, and one or more features of Parkinson's or Parkinsonism.
Like that somebody comes in and this keeps happening. What would?
Yeah, I've got a full list of hallucinations. You bet. Yeah, no, it's great.
Is there an all?
It's a great question for a couple of reasons. I don't think we as a medical community, maybe we do, understand the importance of those hallucinations when we're working with Parkinson's disease and other cognitive issues. So I'm going to list out some of those that we see. These are some of the supportive clinical evidence. I'm scared sometimes to ask the question of patients. If I suspect Parkinson's disease, can you still smell? And if they tell me no, and it had nothing to do with COVID, you'll notice if we went back on that picture, the sagittal view of the brain, there was an olfactory tubercle right in that area. People will often lose their smell before any of these symptoms start to come on. Yes.
My husband lost his sense of smell probably 15, 20 years ago, and now it's starting.
Really?
Yeah,
Wow.
I know.
We'll take it. We'll take it. Yeah. I had a patient. I had a patient one time who came in and his father and his father's father had Parkinson's. And he was 35 at the time. And he asked me, goes, what's the chance I'm going to have it? And this was before you could really look at SCNA, genes, things like that. And I asked him, I said, can you still smell? And he said, no, I lost my smell. And I was like, well, here's what this might be. And that's such a hard question because it's not 100%, it's not absolute. Now you run the risk of making this poor gentleman worry about getting Parkinson's disease, but you also want to be honest with your patient. And they ask the question you want to answer. So that sometimes is a little bit, sorry to say, kind of thing. Okay, we talked about some biomarkers. Some of the advancements that have been made are with SPECT and PET scans. You'll see a lot of this used, for example, SPECT. Stat scans are used, and that's looking for dopamine uptake. And if we see that we've got a loss of dopamine uptake, And probably we're talking Parkinson's, Parkinsonism. We can see amyloid plaques with some of these. Where we use them in the dementias is they have radio trace specific ones for specific ligands. And if you're missing or you have decreased in a certain type, it'll say, well, this is probably Lewy body and it is in the parietal cortex. Because it's black over there. It's not absolutely 100%, but now we have domains, we have hallucinations, Parkinsonisms, and now we might have SPECT skin that says X. Some of the other things we look at, we don't use these in the United States, the myocardial scintigraphy. They use it in Europe. The reason we don't is it doesn't, well, I should say we. I don't see a lot of use of it. Probably because it's very expensive and it doesn't add a lot to what we can already know with the other tests that we do. It's not going to weed something out and say, oh, this is it. So I don't see, I've never ever ordered one. I'm not even sure I know how to order one. You might have to look it up.
How are the other stamps, the spectrum, are they expensive, available?
Medicare started paying for, I think it was the PET scan 2 years ago. So if there's a question of dementia, the whole reason this is something evolving is there's some new medicines out for dementia. You may have read about them. They're monoclonal antibodies. And in order to get those, you have to have a definitive diagnosis based on the PET scan and CSF or now serum biomarkers. The theory is that it reduces the amount of amyloid plaque in the brain. Amyloid plaque is considered a bad guy in dementia. What, I don't write them. And I'll tell you why, because there's about a 30% chance you're going to have cerebral edema or a bleed. They're incredibly expensive. They were fast-tracked through the FDA. And there's no concrete evidence that they do anything more than what donepezil and memantine will do. Theoretically, it makes a lot of sense. Logically, it's there. But I don't know. So when I look at it and I say, well, it can only be used in mild cognitive impairment of the Alzheimer's type, not Lewy body, not Parkinson's. It's going to cost this much. We got to do these many studies, have a risk of a bleed or enlargement of the brain, and I don't know what the results are. I'm like, I'll wait for a little more evidence. Now there are memory clinics that are on board with them. There's a new one coming out that appears to have less edema and bleeds, and when that comes out, I'll probably reevaluate at that time. But it's pretty costly. That's why I bring up the SPECT and the PET scan, is because they have to have that evidence. The EEG, those are pretty inexpensive. They're very soft, though. This data here is very general. If you see a fluctuation in the theta and the alpha region, it can mean 100 different things. It could be metabolic encephalopathy. It could be you're on a lot of benzodiazepines, opioids, things of that nature. But it's a piece of the puzzle. And I keep coming back to that because that's what this diagnosis is. It's, okay, I've got this, now this, and now this, and now this. What does that best look like? You'll see in the bottom there, possible versus probable, one core clinical feature and one indicative biomarker is a possible diagnosis. probable is gonna be 2 or more clinical features, or 1 core clinical and 1 biomarker. I don't think in the general neurology practice, which I'm in, and most general neurology practices, they don't go to this level. If you go to a movement disorder clinic, they might get to this level, and I'm not even sure they do it there. And why is that? Because there's no real difference in treatment. So this is more of an academic thing. I do it because I'm really interested. And it's like, I want to know, is this Lewy body? Is this Parkinson's? Or are we really dealing with frontal temporal? Okay, how do we take care of this? So for dementia, we know that cognitive and physical activity will help. I send so many people to speech therapy for cognitive rehabilitation. I want them to have those techniques of how they can remember. We work with the neuropsychologist from Mayo Clinic, and she and I work together to put together a little bit of a handout that we can give patients that have cognitive concerns. What to eat, what exercises, what brain games can you do, what should you avoid, kind of thing. And I try to give that out to as many people as I can that I have concerns for. The meds that we have are broken down into 2. The first one's an acetylcholinesterase inhibitor. There's 3 types. There's donepezil, which is also known as Aricept. There's lamantanine, known as Namenda, and then there is galantamine. I haven't written a galantamine script for 20 years. Why is that? Because the data all says they're probably equal. Donepezil I like because it's a pill form. If people have nausea or GI upset, I'll take them off of that and put them on rivastigmine, which is a patch, bypasses that metabolism. Some people say, well, why don't you just start them on rivastigmine? Because people usually like taking pills and put a patch on. So I'll start there. When I talk to patients, I ask them to think about a bridge. These are the neurons, and in between is the synapse. Think of that as a bridge. These are the action potentials coming across and back and across. What donepezil does is it kind of helps support that bridge. That bridge right now isn't as strong as it was when it was built, and we just want to strengthen it a little bit. Memantinine, which is a med I'll go to second. I always start out with one of the acetylcholinesterase inhibitors. I explain it as we're reducing the attack on that bridge with memantinine. They're both generic. They've both been shown to be okay, and there's minimal side effects. My feeling on it is if those 3 things align and there's a potential uptake or a potential improvement, then I'm willing to give that medicine. If the monoclonal proteins for mild cognitive impairment, I won't do it because I don't think the benefit outweighs the risk. But in these, I maybe have a chance to flatten the curve on the memory loss. So I'm going to do that.
Would you use them in tandem? Both?
Yes, yes. And in fact, that's a great question. Let's take a patient that has a MoCA, let's say they're 72, and they have a MoCA score of 24, 25, which is 1 tick off of normal. But they're demonstrating some signs of dementia. We get the serum biomarkers, and if those come back, the p-taus are elevated and the beta amyloid's low, which that combination suggests is consistent with an Alzheimer's or a dementia. Even though they are 26, I start them right then on donepezil. They take donepezil for about 6 months. and then I put them on Memantine. So within a year, they're on both. Methylphenidate is more going to be, and we're going to talk about that. That's more for people that have some hypersomnia, daytime fatigue. It's going to give you more energy, and by that default, you feel like you have better memory. So it's not working underneath to help the mechanism of action, but it's making you feel better. It's giving you more energy. And so if I have that, I'm more likely to, oh, my memory's better. Armodafinil, modafinil, Adderall, these are all that we use to, do that. But it wouldn't be a traditional prescription right out of the gate for somebody who has dementia. Any other questions? Let's see if I can get the right. Got it right. So coming back to the question of hallucinations. I think that this is probably undertreated. I think we don't probably ask enough questions as providers about this. That's Hornberger's assumption. I don't have any data to prove that. That's what I think. You can see hallucinations, children, seeing adults. These are going to be your visual hallucinations. You can also have, I see a lot of this, passage hallucinations. And what they'll describe it as is something just goes by my periphery. There was a dog, there was something that went, but I turned my head. There's nothing there. And I've been kind of interested in why is there something in the water in Casper, Wyoming that's causing this? Visual illusion. You can see this once in a while. They'll see a garden hose and they'll say it's a snake. So it's something that looks like it, but it's not. Presence hallucination. It's a little bit like the passage, but it's like somebody's right there, somebody's been there, and now they've left. But there was never anybody there. And nobody left. But boy, I'll tell you what, trying to convince that patient of that, which is not a smart thing to do. You just kind of go, yeah, okay. Yeah, let's talk more about that. How often does this happen? You see other things like this. And I always want a caregiver there when I'm talking with somebody, because we're talking to a person with dementia. Are they really going to remember all the things that you want to ask? No. But a caregiver, well, there's part of my neuropsychological test that I do with patients is there's something called AD8. And it's a set of some, how's your judgment, for example? The patient will go, oh, my judgment's fine. And the caregiver will look at it and go, what? Are you kidding? You just spent $2,000. What do you feel? So it's nice to have that caregiver. And then Capgras syndrome is kind of interesting. It's that, so my wife's sitting right here, but my wife isn't sitting there. There's an imposter sitting there. It's not my wife, it's my imposter. It's an imposter. I have not seen Capgras syndrome, but I know it's reported in the literature. Delusions. We'll see those too. In fact, I should have said, we've talked about umbrella terms. Well, psychosis is really kind of an umbrella term for hallucinations, delusions, and paranoia. And we can see this in the alpha-synucleinopathies, which is part of the Parkinson's disease spectrum. So persecutory, you're after me. You're trying to kill me, kind of thing. Delusions of reference. seeing something on TV and it's directed at me. So-and-so is coming after me. Othello syndrome. Your spouse or partner has been unfaithful when they have it. And then delusion of theft. Somebody's stealing from me. Somebody's taking my money, but they're really not. Here we go. So we were talking about dementia, Parkinson's. Hallucinations are the best single predictor of whether a person will get dementia. And it's a 20-fold increase.
Is there like a difference, like if you're taking a med and you start having hallucinations, but then you go back on your med, is that still the same thing?
No, great question. Absolutely not. Dopamine agonists are kind of known for this. I don't see it as much in levodopa, but with like ropinirole, pramipexole, you'll see more hallucinations. And if you back them off, it's because you're getting too much dopamine, is what it is. It doesn't mean you're having, well, you are having hallucinations, but it's not because of X, Y, or Z. It's because you've got like D3, I think it is, dopamine 3 receptor that's getting charged a little too much. Yeah. Yeah.
What about hallucinations as far as hearing music?
Yeah, absolutely. Absolutely. Those are auditory hallucinations, and that can be part of it.
I think the background is.
Yep. I hear a bell over here. It's not a bell. I hear a person talking to me over here. There's not a person. Those are auditory. Not as common as visual hallucinations, but certainly part of this. And you treat them the same way. So we're gonna talk about that. Okay. One thing that when I talk to somebody, well, let me step back. When I see a Parkinson's patient, I have a form that I go through, and it's how are your motor symptoms, but it's also how's your memory? We do a motor test. How is your depression, anxiety? Are you having hallucinations? And if they say hallucination, one of the things I ask about is pain. Because sometimes people can think they're having something, but it's due to something else. And so decubitus ulcer, if they're a nursing home patient, fecal impaction. So you make sure those are not part of it. To your question, your reduced medication that could be causing some of this, and see, okay, well, is this, you can usually correlate it. Yeah, I went from 4 milligrams of ropinirole 3 times a day to 6 milligrams, and now I'm seeing things. With the dopamine. The bottom point here is, I think, important. If I ask somebody if they're having hallucinations and they say yes, and if I say, are you scared? Are they scary? Are they impacting your quality of life? They go, oh, I have one guy who's like, oh, actually, they're kind of nice. I said, talk to this person, and I won't treat them. I don't think the risk of putting a medicine on for something that's not problematic is worth it. So if they're like, no, they don't bother me, I know they're there, so we won't treat them. Because my belief in medications are good, but they also have bad side effects, interactions with other drugs. And when you do start on meds, I always believe you start low and go slow to where you get. Yes, it may take an extra 3 weeks to get there, but you've had this for how many years? 3 weeks isn't a matter. So I'd rather make sure that you're not gonna, what I see sometimes is if you ramp somebody too fast and they have a side effect, they're like, I never want to touch that. Please don't ever give that. Put it on my allergy list. You know, was it really because you had a problem, or we just took it up too fast? Okay, medication for the psychosis part. There is some evidence, practice evidence, I would say, that when we put people on medicines like donepezil or memantamine, they can have some improvement. So I always will start, well, if it's a pure psychosis, I don't start out with that. But usually psychosis isn't too far off of dementia. So I've got a reason to start on this. This medicine, pimavanserin Nuplazid, it's approved by FDA for Parkinson's disease psychosis. And my experience has been very good with this medicine. The problem you got to deal with is if you're not putting in Parkinson's disease psychosis or hallucinations, insurance kicks it back to you. And even when insurance does pay for it, it can be kind of spendy. So if I can't use that medicine, I'll come down to some of the atypical antipsychotics. Seroquel is the one I usually go with. I'll start at 25 milligrams a night. Its half-life is fairly short. It's going to be running out sometime in the morning. So I'll see how they're doing in the day and then add in the morning. There's a whole list of atypical antipsychotics. There has to be some care when you prescribe these, because what are they doing? They're partially hitting that dopamine receptor. So in Parkinson's disease, we're trying to get as much dopamine into those receptors as we can. Well, if I have somebody taking up half of one of those, maybe their cognition or maybe their hallucinations are better, but now they're doing this. Or if we fill it too much, you ever seen tardive dyskinesia? Tardive is when there's too much dopamine, and you'll get orofacial, or you can have truncal. It's moved like this. And so the solution to that is to take them down on their medicine. It goes away. It's just too much dopamine. All right, depression. I won't go into a lot of the numbers here, but other than to say it's fairly prevalent. And I can understand why. I have Parkinson's disease. My symptoms aren't controlled. Now I'm starting to lose my memory, and I can't sleep very well. I mean, there's reason for it to be there. You'll see people that'll be, just no energy. Well, what we don't understand, what I don't think people understand is that also affects them. Why do I want to think? Why do I want to do this? Or if you start to get that depression under control, maybe that memory gets just a little bit better. Not because of any mechanism, but because they feel better. Coming back to your point on methylphenidate, I feel better. I've got more energy, ready to go. So I'm an advocate for treating depression. CBT, cognitive behavioral therapy, in both depression and anxiety, is pretty amazing. Unfortunately, in Castle, Wyoming, we don't have a lot of trained cognitive behavioral therapists, so I don't have the opportunity to use this as much as I would like. But we know that it does work. Medications, they're mostly the serotonin reuptake inhibitors, Lexapro. That's the one I use mostly, is Lexapro. I don't use Paxil as much because there can be weight gain. Lexapro has some weight gain, but I don't see it as much. Celexa is the first drug that came out. It's associated with escitalopram or Lexapro, not a lot of difference. So my habit is to use escitalopram. The serotonin norepinephrine reuptake inhibitors are another good choice. And of that class, I like venlafaxine or Effects. So those are the meds that I I use for the treatment of depression, and they work. People get better with this. So we're treating this spectrum of things. And this is just one of those things that we're treating. You're never going to get them all right at one time. You take the first one and you say, this is the worst. This is my priority list. We're going to make this better. Then we're going to make this better. Then we're going to make this better. And you just go down the line. Anxiety. A lot of this is tied to off symptoms. So when you're on with Parkinson's disease, you're not having your symptoms. If you're off, your symptoms are coming through. We'll often see it before dose, the intradose. You take your levodopa, Zageline at 7 a.m., your next dose is at 1. At 11:30, you start tremor, or you're a little slow. And when that happens, you become anxious. And we know anxiety causes that tremor to be worse. And so, how do you fix that? Well, you'll probably fix a little bit of anxiety by making the amount of dopamine last longer with something like entacapone or Rytari or whatever the med or deep. I will tell you, I'm a huge advocate of deep brain stimulation. We can talk more about that if we want, but you have to level that out. Then you can lower that anxiety. Anxiety, you probably have seen it in people. They'll get rapid heart rates, they'll shortness of breath, they have difficulty thinking. The treatment is similar for depression. The SSRIs, the SNRIs, and on rare occasions, benzodiazepines. Of the benzodiazepines, I like clonazepam or Klonopin. It has a long half-life, so you don't get this spike up and down. It's more smooth. Talked about that. Apathy. I just don't care anymore. Just leave me here. That's where methylphenidate comes in, or armodafinil. Let's get you back up. Let's get you going. But it's something that we see in patients with Parkinson's disease. When I was putting this together, I actually learned something on the dopamine agonist used for apathy. I've never used a dopamine agonist in apathy. I probably will try it when I see apathy, because we can really get some multiple birds with one stone if we do that. Impulse control disorder. These are things like disinhibition, compulsivity. I'll tell you a quick story. I had a patient who came to me, Parkinson's disease, and we started her on ropinirole or Requip. We started titrating her up. We got her up to, I think it was about 16 milligrams total daily dose. And the granddaughter came in with her on a visit. She goes, man, Grandma is doing so great. She's walking, she's not tremoring. But can you tell me why she's up at 2 in the morning buying everything off of Amazon on the internet? I said, yes, I can. So down we went on the dopamine agonist. The last thing I'd like to touch on are the parasomnias. REM sleep behavior disorder in Parkinson's disease is something we'll see. In normal sleep, you have N1, N2, N3 stage in the REM sleep. REM, in normal sleep, we get complete atonia, which is loss of muscle. The only thing that moves in our breathing and our eyes. That's when we dream. In Parkinson's disease, what happens is you don't get the loss of muscle, so you start acting out. I've had patients that literally hit the spouse will say, yeah, they come. You've seen that, yeah? They come at me, and I'm like, I had one patient that grabbed his wife by the neck because of this. And so You treat that with, you can use either clonazepam or melatonin. Usually has to be a higher dose of melatonin. I start with melatonin unless I have an anxiety issue associated, then I'll start with clonazepam. And my experience has been it's pretty beneficial. I can get them under control with one or the other of them. The other thing it can't do is just go right to that diagnosis of REM sleep behavior disorder. Do we have restless legs? Do we have obstructive sleep apnea? Do we have anxiety that's leading us to lay down at 10 but not go to sleep till 1 in the morning, get up at 3 to use the bathroom, and then I'm up for the day? So you kind of have to take each of those and weed them out. So in conclusion, we know that Parkinson's is a neurodegenerative disorder. We know that Parkinson's has motor and non-motor symptoms. And my hope today is that you walk out of here today thinking of Parkinson's as the motor, but also having cognition for all the other things that can go along with Parkinson's disease. And then I won't go through them all, but those are the ones that we talked about, and that we do have pharmacologic and non-pharmacologic treatments available. Thank you. Oh, thank you. No, you're gonna make me turn red here with that. Thank you. Are there any questions?
I know something that would like to say, you know, right, something about is nicotine, have you heard anything about that? Like the nicotine patch, you know, people put their today and that kind of thing. But I was reading just a study they did with Parkinson's. That was, if they have such like the medication relievers, so that is there something to try in the carbon working? Is the symptoms aren't?
The answer would be no.
Okay.
There is some research on nicotinic receptors in movement disorder, but my pat answer every patient. How many people have heard of Prevagen?
Yeah.
How many people come in and say, well, should I be taking Prevagen? I'm like, I have no idea. There are no well-controlled studies. There's no randomized clinical trials. There's nothing out there that says this is going to help. I don't think it's going to harm you. So if you want to spend $70 a month and to take it, but I cannot tell you that it's going to help. And I would say the same with me.
Okay.
Is that there's research going on with nicotine receptors, but it's not something that's on the market now, to my knowledge. And it's not something I would suggest to somebody.
Okay. Thank you.
You're welcome. Yes, sir.
Can you talk to DBS a little bit?
You bet I can. I'd love to. So first up, I get paid by nobody back. Okay, just gonna tell you that. Deep brain stimulation, I think, is a very good advancement. Initially, when deep brain stimulation came out, I believe it was for just essential tremor. People were kind of hesitant and they were like, nope, you got to fail everything and then almost die. And then I might think about putting you on it. Okay. In my practice has totally gone the opposite of that. Let's say somebody has Parkinson's disease starting at 65. And we've confirmed, maybe through that scan, UPDRS testing, that it is Parkinson's. I can spend the next 10 years using medicine and multiple visits to try and control this. And then when you're 75 or 78, put a deep brain stimulator. Well, what's the increase in risk of surgery? at 65 versus 70. And if I can control things better with something like deep brain stimulation, and you don't have to take levodopa 3 times a day and ropinirole 3 times a day, and here you take an extended release, but don't take an extended release here, but we're going to put some amantadine in the morning. Why wouldn't I want to do that? So what I do with DBS is first I make sure it's a diagnosis and I've got the right diagnosis. They go through neuropsychological testing. They have to do the UPDRS testing. I will wait 2 years for the Parkinson's, because what I don't, like, say I see you tomorrow, diagnosed Parkinson's. We're going to spend time with medication. At 2 years, if you, let's say we've got moderate control, you're on levodopa 4 times a day and Rozagine. And you said to me, Doug, I just think that it would be beneficial, or I'd like to further consider DBS. I would be open to that. Why the 2 years? Because Parkinson's disease will present over time. And if I'm kind of on the cusp of this Parkinson's, I certainly don't want to do a surgery that is something like that. It turns out it's not Parkinson's. The other thing, essential tremor. While they're distinct entities, you can have some similar type symptoms, and the placement of DBS is different in Parkinson's disease versus essential tremor. So I don't want to say you have Parkinson's and all of a sudden you have essential tremor and that lead is going to be no good. Or minimal, let's say. So that's my take on deep brain stimulation. It's been on the market 20 some years, 25 years probably. I think that the surgeries are becoming much, much more refined. I only work with neurosurgeons that have a lot of experience in placing DBS, mostly out of Denver, where I send patients, but there's some people at the University of Utah also that do a nice job. Yeah.
Is DBS primarily for motor symptoms?
Yes.
Most of your talking about non-motor symptoms.
Yes, right. So in the motor, deep brain stimulation will definitely help in tremor. It will help with some of the bradykiniasias and rigidities. Minimal, but some effect with gait. I'm not aware of significant improvement outside of maybe apathy and the non-motor symptoms. I think I couldn't tell you. And in fact, before any I don't want to say any, the neurosurgeons I work with, they want a neuropsychological assessment because there is a small possibility that we can worsen cognition with the placement of the DBS lead. So they want to make sure that, now I'll tell you, I'm going to diverge a little bit here. I have, quickly on top of my head, 5 patients that would be tremendous DBS candidates, but they can't because of their neuropsychological. They just not felt, they feel their cognition could worsen with DBS. So there's a new product called, I call it bivalent. I'm not sure if it's the right pronunciation or not, but it's like an insulin pump. And what it does is it pumps a form of levodopa 24 hours continuous into a patch that you put around the navel. And you just change that patch out every morning. And I have these 5 patients that can't do DBS. We're seeing them next month to start them on this new product. Because then what we can do is, I have patients that are taking levodopa 6 times a day just because it's doing this. Well, the hope here is going to be maybe we get them down. I'm not convinced we're going to get them completely off meds, but if I can get it down to where maybe they're taking a Rozagine and 2 or 3 doses of levodopa, Yeah, that's gonna be a lot more convenient, a lot less often.
Does Medicare cover it?
Great question.
Yeah, they're working to get it on Medicare. It
Are
was with FDA approved recently, but they do have assistance. For anyone who's under 60, they have assistance, under 65, sorry. They have assistance, but they are very close to you.
Thank you. Thank you for that, yeah. I know the VA has me do a special form and they've been approved. The VA has, so. And we have a lot of that up in Casper. So good for us. Yes, sir.
Both essential tremor and Parkinson's tremor?
Can you have them together? Yes, you can. In fact, there's probably about a 20 to 30% overlap. I have a patient that's, he has a terrible essential tremor. But when I would see him, we'd be talking, and that old, he had his hand on his lap. It was a Bill Roller trail tremor all day long. And I'm like, well, I think that you absolutely have essential tremor. But I'm wondering if you're starting to get a little Parkinsonism. We tried him on my path is usually to try him on levodopa first. If I get response, I probably don't need the PRS or I don't need a DAT scan. Well, as often happens, it was like, well, I think I got some response, but I'm not sure. So I said, let's do the UPRS. And I work with a physical therapy group in Casper that does those for me. And it came back and it was like 40% improvement. So anything over 30% improvement on the UPRS is, yeah, probably positive. So I said to him, I said, well, this isn't over, but it does show some positivity. So I think it's possible that you have Parkinson's. He goes, well, this guy looks like Dan Haggerty on Grizzly Adams. He's like, I don't want to know. And I said, all right, well, let's go to Colorado and get a DAT scan. Went down that DAT scan. No, perfect. No liquid Parkinsonism at all. So you can have some overlap. This one.
What's the UPDRS?
It's called United Disease Parkinson's. United Parkinson's Disease Rating Scale. There's 3 sections. The one we use is the motor section. So what you do is you go into somebody that applies it. They put you through a number of tests. You take, I use 2 levodopa 25 milligrams. 20 to 30 minutes after you take that, they redo those same tests and see what kind of an improvement, and then they'll put a percentage. Usually the neurosurgeons, correct me if I'm wrong, but the neurosurgeons will usually require at least a 30% improvement on UPRS to do DBS. And part of that is they want to make sure it's levodopa responsive, because if it's not, is it one of the smoothly opathy, such as cortical degeneration, progressive supranuclear palsy, which DBS is probably going to help.
They also call it the on-off test.
They call that.
The on-off test.
Yeah, very well could be.
Yeah.
Yeah. It's a valuable tool. I love it. And I send them to physical therapy and say, here, do this.
But is this the one symptom that doesn't have to respond on an on-off test or PRS is tremor? So we know tremor doesn't always respond to medicine, but it does respond to EDS. So like if you're using that as a workout, that's the one symptom that doesn't have to be in that percentage.
What is your primary symptom? Balance.
Primary symptom of balance? Balance is tricky because balance can be so many things. If somebody comes in and says, and I'll tell you up front, if you see me stumble, it's because of spinal issues. And so there's a thing called proprioception. Proprioception is how our feet feel the surface. It sends a signal up to interact with the eye and the vestibular cochlear to keep us on track. Well, if we don't have that proprioceptive thing, we're gonna be like this. In Parkinson's disease, is it really a balance issue? Or is it I'm freezing and now I'm falling forward? Or my body wants to come forward faster than my feet, or my mind's thinking faster than my feet. Where if you have something like neuropathy, that can impact. If you have lumbar radiculopathy, lumbar stenosis, that can impact. If you have something called normal pressure hydrocephalus, that can cause a shock wave, but also kind of a magnetic gate. So when people have questions of balance, it opens up a whole pot of questions. Because I don't know if at that point it's because of their Parkinson's, or do they have a comorbidity that's going along with that that's causing the balance. Yes, ma'am.
You were talking about the UPDRS. Do you use it prior to initiating the dopamine? In other words, if somebody's already on it but has never taken that test, is there a way to test to see whether they're responding well to it?
Yeah, you could. So I've done that. If somebody's taking levodopa, they don't take the dose the night before or the morning of. They go in for the test, get tested, go back on it, then resume their normal dose, and we can see what that percentage is, to see what kind of a benefit. Now, could you, I've never done this, but could you say, okay, well, you're on levodopa 2,500 milligram, one pill 3 times a day, don't be good enough. Let's go in at this time, you take your 1 o'clock dose, once you go at this time, do the pre-test. They will give us, let's see what kind of an improvement. To me, that's a lot of steps. I would rather say, okay, you're having some off symptoms, and I do this with all my patients. I'll say, for 2 weeks, I want you to do this. If that doesn't do it, for the next 2 weeks, I want you to do this. And then if that doesn't do it, I want you to send me a quarter message. I want you to tell me where you're at, and I'll tell you what you're going to do next. To me, that's easy. Sir, you have a question in the back? No, okay, I'm sorry. No. Any other questions? All right. Well, you've been wonderful. Thank you so much.
Thank you so much, Doug. That was excellent. I think everybody really enjoyed it. I'd like to introduce Jody Brown. She's the CEO of the Parkinson Association of the Rockies. She's going to talk a little bit about an upcoming event that we have.
Hi, everybody. I just wanted to clarify E3 event, which is September 20th. We are not live streaming. It's gotten so expensive. They charge us $10,000 now to live stream. So we're just not able to do that anymore. We will record it. If anyone wants to come down to Denver to attend, we can probably get a blocked room rate for you at the Hyatt. So let us know if anyone wants to come down and we can get you a reduced rate. It's going to be a really good event. We are doing a mental health panel, which will piggyback on what Doug has been talking about today. And then there's